Welcome to Public Health Musings, where we dive deep into pressing issues in public health as well as global health trends. After a short hiatus, we are glad to be back to share with you all things public health. Today, we have the privilege of speaking with Dr. Christine Ngaruiya, who's a medical doctor and associate professor at Stanford University and director of the Stanford EM International Global and Population Health section. Dr. Ngaruiya's work focuses on chronic diseases and their impact on underserved populations, especially in East Africa. She has previously been a guest on the show, and I'm glad she's back to tell us more about her work. So join us as we explore her insights into global health challenges, her chronic disease research, and her vision for improving health equity. Welcome to the show, Dr. Ngaruiya.
Thank you so much.
So glad to have you back. Yeah, so glad to have you back and to just chat. And thank you for taking the time to speak with us despite the hectic schedule.
Absolutely. Thank you for having me.
So could you share what initially drew you to the field of global health and chronic disease research?
Absolutely. So first of all, such an honor to be back with all of you and your esteemed guests. And it's an exciting time to be together talking about global health. There are a lot of things going on in the world, but overall, we remain optimistic, right? And so just a little bit of background on me and in terms of how I got into global health and then my area of focus on non-communicable diseases, chronic disease. So I grew up in Kenya, like Prof. Kingori, and during my formative years and was exposed to health and health issues and just this desire to want to go back home eventually at some point and do work there, probably as a clinician. I knew I wanted to be a doctor when I was very young. And so that's what I knew I was going to come back as a, physician and take care of patients just like my hero doctors took care of me when I was a kid. And, I did do medicine, but I learned in undergrad about this idea of health inequity, right, and public health inequity. And it was actually through a sociology of medicine class. And, like so many other things in school, a teacher or a professor can really influence you and just influence your interest in the topic or an idea. And I had this incredible professor, her name is Julie McQuillan, a former mentor, now friend. And she took us through the sociology of health course, and I got to read this textbook where there were all these systematic differences, right, for specifically racial and ethnic minority groups in the US. And it was something that really stuck with me, this idea of thinking about, why these diseases, which really seemed quite simple to have more equitable outcomes around, like hypertension, high blood pressure, even cancer, diabetes, which all seemed to really stem from these, like, kind of modifiable determinants, and seeing that across the textbook for every single outcome, Blacks, Hispanics, Native Americans in Pacific Islanders did systematically worse. And so it kind of lit a fire in me that has never quite gone away. And this idea around health equity and ultimately health justice, and specifically around chronic diseases, because again, I still have this sense that a lot of the solutions can actually be quite cost effective and affordable, and yet there's still these inequities. So that's kind of my origin story, and have stuck with it, for the past, maybe I shouldn't say more than 20 years, and still excited about it today. So happy to be talking about it with you.
Fantastic. And you're in Kenya even right now, right?
I am, as the photo shows.
Right?
Yeah.
Are you conducting research? What is it has brought you back to
Right. So a couple of
back home?
interesting, yeah, thank you so much. So a couple of really interesting ventures. So one is actually this grant writing course with which Prof. Kingori has actually been able to be a part of. And this is our second cohort with the AMREF International University, where we're teaching African scientists based in Africa how to write grants, because we know that it's difficult to deploy programs and projects without money. And yet a lot of training capacity opportunities exist for training on grant writing. And so I'm back actually teaching our second cohort. It's being funded by the Habit Foundation. Very exciting. And it's Ministry of Health professionals across the continent, 21 countries. And then, yes, pushing forward all my research projects. So any PI or professor academic knows that, just kind of have to be there to kind of move some things forward. So yes, touching a few different projects while I'm here as well.
Speaking of grant writing and what has been happening, right?
Yeah.
Recently, with all the cuts, this is a really good segue. So, you know, with the recent funding cuts, a lot has happened and very dire negative effects on global health initiatives.
Mhm.
So, how do you think this will impact the efforts that you and others are undertaking to combat chronic diseases, especially in low-income countries?
Sure. So, I think it affects all of us, no matter what area of global health you're touching. And I think that it's a necessary nudge and push. It's unfortunate the way that it occurred, but I think it's going to catalyze some really interesting collaborations and new opportunities, is my take on it. And I think it's going to push us to work together more creatively because I think the mechanisms and resources that are going to be that are available or are going to be available will require us to do so. And so, I think even though it's, really heartbreaking in terms of the way it's affected so many individuals, whether patients and populations and researchers and scientists and even mentees, young junior people who've just started their careers. I think it's an interesting opportunity to think about how we develop interdisciplinary solutions rather than fighting against one another. This idea of siloed work that has, sort of guided many people's labs. I think, that is going to have to be reflected upon. I think, and even who generates the ideas and how we're putting those ideas out is going to change. I was having a discussion, as a matter of fact, with a mentee recently, and they were a bit alarmed at the state of affairs and whether they should continue in global health. And they were reflecting also on this idea of having to, be a PI and quote, have all the ideas themselves. And we had a really, good heart to heart, I think, where I just told her that, it's actually, I think, a misnomer for you to have all the ideas. You shouldn't have all the ideas, right? And team science and really collaborating and interdisciplinary work is the way forward. I think it's been the way forward for a long time. This is what's going to help catalyze us doing it, maybe even a bit more efficiently.
Yeah, I can't agree with you more. Definitely everything has been thrown into disarray, so much
Mhm.
confusion, but I think it's an opportunity for people to be like, okay, what else can we do
Exactly.
just in case this happens again? But thinking outside the box.
Exactly.
We have relied, especially in global health, we've relied on certain funders for a very
Right.
long time, certain regions to provide funding.
Right.
And so in places like, Africa or South America or those places that need assistance with the global health issues, it's a way to like put on new caps and
Right.
think through the process for the future, right?
Exactly. Absolutely. And I, again, like I said, I remain optimistic. I think that we're going to have some new and different outcomes that will result from this state of affairs and certain new relationships that will be built out of a need, but should be good, hopefully, overall.
So, thinking of these global health issues, I wanted to just dive a little deep into some of those chronic diseases or non-communicable diseases that you are working on. So, what are they, right? And what do you think are the most pressing challenges you see in
Mhm.
addressing them?
Yeah, so there's good news. I think I'm so relieved now, almost 10 years in, a little bit more than 10 years actually, working in the quote unquote non-communicable disease space to see that the tides have turned, that they have become a commonly discussed issue. I'm a feature in your, highly demanded podcast, whereas like 10 years ago, there were these conversations about whether or not they were real, were they even affecting people in certain countries. I was having conversations with partners here in Kenya, and there was a lot of like kind of hand waviness and sort of, this is not an issue that we're dealing with yet. It's a Western problem. So there's a cognition and awareness, I think, in most places. I think there's still some places that are lagging for sure, but that at least they're a problem, and we should be trying to think about solutions for them. So that's good news. Pressing issues that continue, increased funding continues to remain an issue. And, back to our prior conversation about interdisciplinary work, I think the nudge that needs to happen, excuse me, is that no matter what area of research you're touching, or project implementation, public health, is to be thinking about how you're thinking of co-affliction also with NCDs. If you're an HIV researcher, if you're an SRH researcher, if you're a maternal health, whatever kind of area you're touching, it's thinking about, how is that HIV being affected by their diabetes not being controlled? How is their chronic respiratory disease not being, being negatively affected by their, COPD and, the TB concomitant factors, and so many other concomitant afflictions. And it goes both ways, right? Also for NCD researchers to be thinking in terms of integrated care for patients and public health interventions. I think in terms of co-afflictions and thinking about that as researchers, another pressing issue is for policymakers to really be thinking about how are they financing NCD care. It's possible, and I'm proud to say, for example, in Kenya, we have a very active NCD unit that has created a solid number of policies around NCD care and NCD prioritization, and they continue to have mindsets around that and prioritizing it. But I know I've worked in other countries, even in Africa, where that is not the case. And so, it's a missed opportunity. If we're not thinking about it, it's not going to be measured. It won't be at the table with some of the other important conversations. And then I think there's this idea about last two things, a concerted agenda. So I think there are several other folks who've also commented on this in the NCDs field that we haven't necessarily had a very concerted agenda in terms of how we all address NCDs. And, there's like the WHO Best Buys. There was the 2013 to 2020 NCD Action Plan, which since has passed. But implementation of some of those Best Buys is not clear. What order should you try to put things into implementation? How should they be enforced, and even if they're implemented, things like that. And so I think just concerted agendas, and I'm happy to say that I'm actually on part of a working group with the WHO that's currently working on just that question. What is the implementation strategies that we should be using in Africa for NCDs? And it's brought together folks from across the continent. And I think we need that more. And we probably, hindsight is 2020, as we say, we probably could have been somewhat further along, I think, if we had even more concerted agendas that were disseminated broadly. And the last thing I'll say is for those that are just thinking about getting into NCDs or sort of what's the cutting edge, where should I be putting my resource and time? There's the big four that we talk about. So cardiovascular disease, diabetes, cancer, and chronic respiratory disease like asthma and COPD. But there are also neglected NCDs like sickle cell disease, neurological disorders like seizures, and other things that cause a lot of morbidity and are sort of stigmatized as well, and just not as well addressed, mental health. And so, so some of these sort of more neglected areas as well are equally important. We're going to need to start addressing those too. So.
Yeah, and speaking of those neglected areas and then this concerted effort, I often wonder, where is the community in this whole process, right? So that community-based participatory approach. And I wanted to talk about some of the work you've done, like the Bridge to Care. So how do you engage these communities in your work, and what role does their input play in shaping the health interventions and, whether it's policies, whether it's working papers, etc., etc.
Love it. Yeah. And thank you so much for asking that, Prof. Ngaruiya. And I think if this is my flag, if no one's going to listen to anything else on the podcast, hopefully catch this bit, right? Because it affects all of us and all of our work in global health, which is, so community-based participatory research or community-engaged research is so key and so crucial in terms of intervention, design, policy, design, project and research design, and how we implement various interventions. And so, and I would hope that most of the people on the podcast, the listening crowd, have heard it at some point, but how you implement it is a different story for sure. So I had the great fortune of doing an elective in medical school on CBPR with a primary care physician, because that's a lot of where it started, the cornerstone of CBPR. I did this elective that people usually took as a sort of easy to pass kind of fourth year, walkover elective. But I found it very interesting and actually used it to design this program you mentioned, Bridge to Care, now like 10, 15 years ago, targeting refugees in Nebraska to have both health education and promotion and linkage to care. And it's this interdisciplinary student training type of program, service learning program, where the students from across disciplines in my former med school get to interact in Nebraska with these refugees. And it's still gone on. And I know for a fact, for one, this is one of the key points of why community engaged research is so important. One of the reasons it's so sustainable is because it was developed in partnership with community-based stakeholders, including refugee leaders from communities that we were targeting, and other agencies that were focusing on them at that time, like the refugee resettlement program, some of the church leaders and things like who were, helping with resettlement. And there are other examples of that. I've worked in a housing insecure project that was a resident-led team type of effort that's still in existence at Yale, where I was for 10 years, and other things. And so how you get them engaged, and one of the ways I do it through, and many people do it through their own research, is developing what are called community advisory boards. That's a term that we use. And so, for example, a digital health project that we did last year, we brought together a team of community stakeholders, youth that we were targeting with the digital health tool and so on, a group of like 12 people. And they met with us, and we met with them every week. And they, we would go through our project design essentially and say, hey, what feedback do you have on this? Do you think we should do it in this population? What about this population? How do you think we would increase representation? We contextualize the findings with them and so on and so forth. You can even co-publish with them and so on, is usually encouraged in the community, in the CVPR model. And, the funny thing, and I'll end on this, is that we always say people know what they need, so ask them, right? So that's one. But most importantly, is just how much they enjoy it. Like how much they enjoy being engaged in these meetings. They're almost so overzealous that and so keen to be asked, because people never ask them, that they're almost even asking how they can help more, So I think we had one CBPR person, CAB team member last time, who maybe came and observed some of our survey uptake for the digital tool, because they were curious, and so it's really exciting. It's honestly such a fun entity. It doesn't feel like work, and it only enhances whatever you're working on. So yes, big supporter of CBPR, community engaged research.
Yeah, and I find so much energy derived from their own energy. I always say, if all I did was just be in the field, but working with these communities, engaging with them and finding ways to improve their health together, if that's all I did, I would be just fine with the world.
Exactly.
We have to write papers and we have to motions.
Right. PowerPoint.
Go through that whole process. But I absolutely love that process. And it's exciting to know that, you've also worked with refugees in trying to find ways to improve their health outcomes, and all the input and effort that they put in to acculturate, with these communities in the US or wherever they are. So speaking of chronic diseases, I know that with those big four, they present differently sometimes from a demographic perspective. Thinking of gender sometimes, and we've seen this in the literature, where with women, diagnosis for heart attacks is done much, much later than with men. And so I wanted to talk to you a little bit about that work that you've done in some publications on gender differences in health outcomes. So tell us a bit about how these disparities affect the management of chronic diseases, especially in our low-income communities and countries.
Right. Yeah, this is great. And so yes, I was really grateful a couple of years ago to be invited to write a special paper on gendered NCD care and gender differences in NCDs for FACEB bioadvances. And so, and in that paper, and some things I feel really strongly about are the fact that in the NCD space, a lot of our indicators, like if you look at the SDGs and so on, focus a lot on mortality. And yet they leave out morbidity measures as sort of like targets and indicators we should be looking at. And then when you look at sort of the different differences in outcomes, certainly a lot of the times men are systematically more likely to die from these various NCDs, or at least are reported to have died from these NCDs, because we know our data is still quite poor. So a lot of our primary data is still quite poor. But when you look at the same measures or stats around morbidity, it's actually women who tend to be definitely more affected. So they're living unhealthy, longer lives. They're unwell, according to the WHO definition. And yet all of our indicators are focusing on mortality. So you see where I'm going with this, in that if we're prioritizing mortality and preventing, premature mortality, which is still noble, but we're not doing anything to assess, monitor, and address morbidity or prioritizing it anyway for member nations, then women are going to continue to be left behind. The example I give in the paper is on COPD. So when you look at chronic respiratory disease management, women tend to be disproportionately affected morbidity-wise because of indoor household pollution, right? It's the cooking with the indoor stoves. Also, secondhand exposure to tobacco, which they have little control of depending on agency in the space that they're living in, or, maybe working in potentially, and their children too. And I talk about that as one of the case scenarios, and it's easy to appreciate even just that. And again, if we're not prioritizing, measures of severity of COPD in populations and reducing morbidity, that's where they'll be missed. The other couple things I mentioned and I talk about is this idea around, I alluded to it a little bit, the actual indicator measurements, not just on morbidity, but even just on gender-based indicators. So we talk about, again, premature mortality, maybe even increasing screening and so on. But none of these indicators have a gender component to them, at least for NCDs. And so, again, that's a missed opportunity because we know, again, just by level of agency in general, it's oftentimes men that are disproportionately more likely to access the care. And so if we're not ensuring that our targets ensure that we're also getting to, I don't like the term hard to reach, but the less accessible, or the population that is less likely to seek care, i.e. women, for the usual various reasons, then again, we're going to have missed opportunities to address them. And then the last thing I highlight, not just for NCDs, but in general, is just this, continued need to have gender-based research in general, whether that's focusing on diseases that specifically affect women disproportionately, who again are often left behind, things like cervical cancer with NCD space, breast cancer, and so on. But also just measuring and sampling to ensure that women are equitably represented in research studies, which can be hard for all the reasons we've already talked about just now. But when you're doing your sample size calculation, are you ensuring that you're powering for gender, young women, older women, and so on and so forth, so that we're able to see what our different interventions are doing amongst these individuals as well. So I'll stop there. There's a lot more to talk about with gender, but hopefully that spurs some thoughts with folks.
Yeah, and that gives us a good overview or place to continue this discussion, because when you highlighted that women are not easy to access, it's interesting because we say that about men too. When you're talking about men's health and how they don't go to the doctors, you said they do die early. And then it begs the question also, because women, the ones who are able to have children, so they get all these visits, right? They go see the doctor for prenatal or antenatal, etc. So what is happening that they're not integrating, right? This screening for NCDs or catching these diseases early yet. Women, I think, see the doctors a little more, if you will.
So there's
correct.
Right. So there's, I think it comes into just nuance in the way that we target these populations, because, for example, there may be certain screenings, for example, that are, obvious, like hypertension. If you come into the clinician, no matter who you are, hopefully your blood pressure is being checked, hopefully. When it comes to management and control of disease, that may be a different conversation. We did a study, for example, in Pakistan, looking at, I think it was more than 3,000 patients with heart attacks in the hospital there, big hospital there, and we found systematic differences in management. The data doesn't tell us why. We can make hypotheses around lack of agency and control. So, for example, women were less likely to have received all of the four first-line medications that treat heart attacks, like aspirin, beta blockers, statins, and forgetting the fourth medication, I think it was ACE inhibitors. So all four medications women were less likely to receive. They were also less likely in some of our sub-analyses to go for definitive care, which was, to have a clot removed, thrombolysis or thrombectomy, catheterization, right? Again, and that could be differences in disease, but still it's strange that systematically, again, they're receiving less management and then therefore control of disease. And again, some of those gaps, like we said, could be cultural. right? It could be the perceptions of the clinicians and providers. Some of it we believe, as informed by some of the cultural context there, is just that your family or the family unit or your husband, their partner, may be controlling what and what does not happen to this woman. And that's okay. It's not to say that culture should be usurped. That's not the message here. It's just that we need perhaps to have more nuanced ways in the way we reach those women, right? Whether it is screening for certain diseases, I'll go back to like gender-based diseases like cervical cancer and even breast cancer that have a lot of shame and a lot of stigma. And we know that the reason why women death rate often is so high in some of our settings is that women are too ashamed to be screened for it, so they don't go for the screening. They come in too late. So it's like a near universal sometimes death, you know, near universal sort of I can't think of what I'm trying to say. Sorry, can cut this out. A near universal death sentence if you come in for diagnosis with some of these gender-based cancers, right? And so again, thinking about nuance and how we screen is still going to be key. And then definitely around management and control. So, but you're right in terms of there may be differential healthcare seeking behaviors sometimes for women, but what that actually translates into for outcomes is a different story.
Yeah, I like your take on management. It's one thing to be screened and to be told this is what's happening, come back or take your medication. We see that in HIV a lot, that tracking always there are so many gaps and people not coming into care as often as they should for one reason or the other. And that again continues to enhance the disparities that we're discussing here today.
Right.
So I want to go back to the M Health work that you talked about, and you've done this research leveraging mobile health. So can you explain to us how using M Health has helped improve chronic disease management and access to care for marginalized populations? But before you respond to that, we have thrown out a few acronyms. We
Sure.
talk about SDG,
Sure.
NCDs, mortality, morbidity. So I want you to clarify those ones for the folks who are not in the field like us. And then
Sure. Yeah. No, fair
talk
enough.
about your M Health. Yeah.
Fair enough. Fair enough. So Sustainable Development Goals, SDGs, they're the sequelae to the first of their kind, which were unprecedented, the Millennium Development Goals. And they're really just supposed to be a mobilizing set of goals, indicators, and targets that member nations of the United Nations can ascribe to or should be ascribing to in order to guide development for their countries. And development is broadly described. It incorporates some health-related targets and indicators like NCDs, like HIV, like maternal health, child health, but also includes things like environmental development, policy and political affairs development. So they're these broad goals and indicator target that, again, the UN member nations have agreed around that we're hoping to focus on in the next, by 2030. And we'll see where we're at. And I think we might have a sequelae because we laugh because we know we're not doing so great. But yeah, so SDGs, and I mean, but still novel in their creation, and I think better than having nothing. So there's sort of this goalpost that can actually help drive care, and we have seen some positive changes. I'll just add, Prof. Kinori, like with India, and I know child health, things like that. So there have been some good things that have come out of this. As far as NCDs, non-communicable diseases, non-transmissible by definition, generally, things like cervical cancer and HPV and liver cancer and like some of the chronic hepatitis are some of the outliers. But in general, non-transmissible, not transmitted from person to person, usually of long duration, non-communicable diseases, NCDs. And then mortality, death, or a measure of death, whether it's death rate or absolute incidence of death, or how many people are dying. Morbidity is unwellness or living less than the full life that one should be living. Unwell living, not death, but short of that, living unhealthily, morbidity or morbid. So those are hopefully some clarifying of terms. As far as M Health, yes, something else I'm also very excited about. And so, I think that for me, I stumbled upon mobile health technology as an intervention in public health, actually in my master's degree at the London School. And I was interested in health equity, like you heard, like many of you on the call, And my mentor there for my thesis ended up being one of the great gurus on digital health. I'm Dr. Prof. Caroline Free. She's written a few Cochrane reviews on mobile health technologies for care. And it was interesting to me to think about, these mobile phones or phones, we have a few phones probably in front of us, as a one of the possible panaceas for care, right? So, I mean, you can use mobile phones for epidemiology, for data collection. You can send census-based surveys out using mobile phones. You can certainly use them for screening, right? Including whether that's sending surveys or questionnaires to, again, at the population level versus like in a clinic setting. Certainly, we know for electronic health records that are taking over the continent, especially Kenya. We know that electronic health records have the potential to truly transform quality of care, data collection, and just the day-to-day efficiency of care, as well as for health promotion, health education, linkage to care, and so many other things. So, where I've come in working with it initially with my work the past 5-6 years has been using it for health education, health promotion. So, for example, we have a digital tool that we adopted from the US. It's a texting tobacco cessation tool that we've adopted for the Kenyan context and are currently starting a trial on in patients at our largest hospital. And there are other really exciting additional mobile health-based tools like for mental health screening and education and even support, long-term support. And then we have a few other tools that we've designed, one including a multi-way educational tool on NCDs for kids. So there are a lot of really interesting ways that it can be used. And I think what excites me the most about it is those areas where we have the least amount of resources. So NCDs are chronic, non-communicable diseases are chronic in nature and their risk factors, right? But we don't have a lot of tobacco educators. We don't have access to a lot of alcohol navigators. We don't have a lot of mental health providers, right? And care practitioners. There's a shortage globally, especially, and in LMICs, low resource settings, especially. And so I think about how can we then use the phone that, up to 80% of the continent, if I talk about Africa, has, like, how do we use those phones to in lieu of to support in those areas that we need sort of some long-term care. And I think the same message goes for HIV care, right? It's this idea of longitudinal care. You need to keep coming back. You need a reminder, you need education and these kinds of things. So I really like it around that idea of risk factor management and even for mental health.
Fantastic. So we've talked about quite a bit.
Yes.
And as we are now trying to wind down, and there's so much we could go for 4 hours and talk about these things that excite us. And I think that's what I like about health, because it's relatable. It's what people are facing, so we can talk about it forever. But I wanted to just now, pick your brain on what do you see as the next big steps in global health research in relation to non-communicable diseases. What other emerging trends or technologies excite you?
Yeah. So I think kind of like we touched on before, some of the next big steps will be thinking about how we do integrated care for NCDs with other diseases. We talk a lot about NCDs and HIV, but I think there's going to be a lot of other intersection. I mean, there's a lot of discussion about planetary health now, and there's a lot of discussion around, One Health. So I think there's a lot yet to be untapped there, and really sitting together and thinking about targeted solutions across that are even more cross-cutting than we have been. And I've been sitting in some of those rooms learning a lot. We all have a lot to learn, I think, from each other, but learning a lot and thinking about ways that we collaborate and think about interventions that way. We actually have a project currently that's funded by a very small group, the International Strategy Forum, that's looking at, for example, boda users or motorcycle bikes and their impact on the environment, and teaching them about that and climate change, as well as on their lung health, right? Because again, we know, like we talked about, chronic respiratory disease, emissions, and motorcycle drivers are at highest risk. And so things like that, just really kind of going a little bit, like you said, outside the box, Prof. Kingori, and thinking about true intersection of work. And then I also am really keen on how we start to think about some of the neglected NCDs, like I mentioned before. Sickle cell is something that's become closer to my heart as I've met sickle cell warrior, as they prefer to be referred to. Really awesome community-based group called Uhuru Trust, led by a really amazing woman named Eunice Owino. Maybe she'll see this. And other diseases like that, like I said, seizures that are so stigmatized, and we just know kids end up dying or just kind of locked away in spaces because it's shaming, and other things, rheumatic heart disease. There are many others that we haven't addressed, but that people are suffering with. And I think that there are specialists for these different areas. Thinking globally in terms of ways they can impact this as well will be super helpful.
Fantastic. So, speaking of super helpful, folks
Mhm.
who want to be helpful
Yeah.
and I want to get on this bandwagon of NCD prevention and management, how can they go about doing that at the community or policy levels?
Sure. So, one organization that's come about in the past decade that's been a real great mobilizer for NCDs, the NCD movement, is called the NCD Alliance. They have chapters by region and often by country that are both, research focused, a lot of advocacy, especially, and then community-based work too. And so I recommend for folks that are interested in it anyway, no matter what your area of work, including being a community-based person or, a lay population, as we say in medicine, who's not a medic or, a public health researcher, that would be a great way to start. They usually run programs and things. And then if you are someone who's in maybe research or even clinical work, thinking about, is there an NCD unit at your in your country? And how do you access them? Are there ways to link into programs and projects that they're working on? Because I think that's always one of the best places to start is where does the ministry or where do the policymakers need help and guidance? And then, like I mentioned, lastly, there are a ton of community-based programs. It's just a matter of sort of picking, or community-driven programs. It's just a matter of grassroots programs, a matter of picking your interest. For cancer, for example, there's the aortic program. In Kenya, I know there's Kesho, which is the Kenya Society for Hematology Oncology. So, and they also encourage lay people to join. So it really depends on picking the disease, sickle cell, Uhuru Trust, like I mentioned, picking the disease focus, getting passionate about something, and then committing to it, finding what could be going on in your community and just putting yourself out there.
Fantastic. That's a really nice way to start, you know, thinking about how to be a partaker
Mm-hmm.
of this process.
Mm-hmm.
So you've done so much in your young life, and when you reflect on your journey, what has been the most rewarding aspect of your work? Whether it's global health, whether it's the NCDs, whether it's medical, like what has been, and I know there's going to be a lot, but what is that a few things that stand out that can also help motivate someone else?
Yeah, absolutely. I mean, that's pretty easy for me, I think, and for a lot of people. I'm not gonna give some, mind-blowing answer. It's really seeing other people grow. I think one of the most magical things is watching someone that you knew start, undergrad basically as a kid, right? And then graduate and go have some like big job with, and I don't, it doesn't have to be a big job, a job, an impactful job is what I mean, with, with a nonprofit and work on their own public health interventions that way go beyond anything worked with them on or taught them or just land their job in development or discover something because of working with you that, piques their interest. I can say that I'm very proud that I've probably directly affected maybe 20 trainees or mentees directly on NCDs that maybe either didn't know about it before or kind of, now have it in their armamentarium and, think about it or come back to me for questions on NCD related work. And that's exciting to me. I think it's like again, it's like this it's overplayed, but think about the next generation and just watching them grow. That for sure has been one of the most rewarding things to me.
Yeah, I always say passing the baton is always such a fantastic, altruistic thing to
Mhm.
do. And because there's so much to do in global health
Mhm.
and in health
There
in
really is.
general.
Yes.
And because of how just all the connections to health, it's not just you being sick, but are you working? Where you're working, is it healthy? Where you're living, is it healthy? All those social determinants of health, they make a huge difference. And learning that in school was, I was like, yes, this is what I want to do for the rest of my life.
Right.
So thank you so much, Dr. Ngaruiya, for sharing your valuable insights and experiences with us today. Is there anything else I didn't ask that you want to share, or your last few comments as we end the podcast?
No, this was excellent. Thank you so much for creating some space for me and just talk about my career and also NCDs. The next UN high-level meeting on non-communicable diseases is actually this year in New York in the fall, I believe September. And so if you're anyone who cares a little bit about any non-communicable disease, have been personally affected, have been thinking about it in your work, think about ways to get involved to start increasing education and awareness around NCDs, lining up to that. So our policymakers know how important NCDs are and what we really want them to prioritize at that meeting. So get involved, get your voice out there. NCD Alliance, like I said, other community-based programming. And yeah, look forward to seeing many of you on the journey.
We're so glad for your dedication to improving health outcomes for underserved populations. You have inspired us and continue inspiring us, even as I follow your work. And I do look forward to seeing you continue leading in the global health space. So for our listeners, be sure to check out Dr. Ngaruiya's research and initiatives. And until next time, stay engaged and informed with public health musings. Thank you, everyone.
Thank you.